Megan is well known to many of us. She's a social psychologist and associate professor at the Fred Hutchinson Cancer Center and received her PhD from Baylor with a postdoctoral fellowship at Memorial and a faculty appointment at Weill Cornell. She is an expert in health communication and decision making amongst patients with advanced and serious illnesses, and specifically her work examines how cultural and social environments influence how we interpret information and make decisions. The program of research focuses on understanding and developing tools to support patients and families in making informed healthcare decisions at the end of life and coping with advanced illness. She has focused primarily on health equity, examining how to adapt interventions and support tools to serve the needs of diverse patients with advanced and terminal illness. And she's received multiple awards for her NIH-funded line of research. As she is an American Academy of Hospice and Palliative Medicine research scholar, and her work has been featured in the Huffington Post, USA, Forbes, Psychology Today, NPR, and on CBS Los Angeles. And so now live from the Fred Hutchinson Cancer Center here at our conference.
Thank you so much, Dr. Lind. I appreciate it. And thank you all for having me here. I know most of you through our various research collaborations, and I'm excited to kind of present my body of research a little more fully during this time. So thank you. So yes, as mentioned in the intro, a lot of my work focuses on specifically advanced care planning and thinking about how we can ensure patients are informed decision makers. And I'll be talking a little bit more about that work today. So I'll give a little bit of background about sort of my motivations for this. A lot of this, you are all probably somewhat familiar with the research literature on this, but what motivates the work that I do, an overview of my research program, and then some of my ongoing current projects, just to give you a sense of the work that I'm doing here at Fred Hutch. So a little bit of background on why I do what I do, and that is that high quality end-of-life care does require good communication. And so as somebody who is a communication researcher, I'm always interested in thinking about how we can make sure patients are informed in all of the care choices they're making, and that includes care received at the end of life. But of course, for patients to do that, they need to ensure that that care is documented and communicated. So this, of course, includes formal documentation through advanced directives, living wills, healthcare proxies, DNR orders, but probably and perhaps most importantly through having the right conversations. And there's a bit of a debate in the field right now for people who do this work in the research space about, what even is the value added of advanced care planning. And I think people fall on various sides of this, but I think most would agree that the documentation itself doesn't carry us very far. We have medical record systems that don't communicate across systems. We have patients' continued changes and preferences and things like that that affect the effectiveness of those documents. But certainly having those conversations with family members, loved ones, surrogate decision makers, providers can help ensure that patients do get the care that they want at the end of life. We also know that, prior research shows aggressive care at the end of life often fails to prolong patient survival, which in most cases, if a patient is seeking fairly aggressive treatment with an advanced stage cancer, that's often their primary goal, is living longer. But there is some research to suggest that in many cases, depending on illness status, prognosis, and all of that, that aggressive care actually fails to do that. It can negatively impact patients' quality of life. It can be very costly, which can be really challenging for patients and their family to afford those types of care. And perhaps most importantly, it can run counter to the patient's own preferences and values when we actually sort of ask them about and assess what those are. We know that advanced care planning is associated with better quality of life at the end of life. And specifically, cancer patients who've engaged in advanced care planning report better quality of life, less suffering at the end of life. They are less likely to receive what we would call futile aggressive care. So again, aggressive care that's not prolonging a patient's survival time. There's more likelihood of them receiving care consistent with their own preferences. They're less likely to die in the ICU, which most patients explicitly, of course, state not a preferred place to die, and lower healthcare costs at the end of life. So we know there's a lot of benefit associated with it, which is why over the last decade or more, there's been a really strong push in ensuring that patients are having these conversations and documenting these preferences. But despite it being standard of care, despite us knowing those benefits, a large majority of patients still don't engage in this type planning. And so there's a clear need for improving the rates of engagement, the types of engagement patients are doing. So patient engagement in advanced care planning, it's now, kind of just widely known this is the standard of care. This is just a few of the groups that have led some of that, but across multiple aspects of oncology care, this is a known standard of care. But even among patients who have an advanced cancer, many of them aren't engaging in advanced care planning. And this data comes from a large cohort study of patients with advanced cancer that was a national cohort, and found that only about 48% of patients who had advanced cancers, a prognosis of estimated prognosis of 6 months or less to live, only 48% of them had even engaged in advanced care planning. So even among patients that we would deem as most in need of this intervention or this documentation, many of them have not engaged. And so part of it is thinking about how we are having these conversations, how we're introducing advanced care planning, and how we're ensuring that patients do receive the care that they want. And so prior research, of course, has attempted, there have been a number of interventions to look at how we can improve rates of engagement in advanced care planning among patients with cancer. And this is from a systematic review that looked at the efficacy of different advanced care planning interventions across 55 studies. And it found that these interventions had a really limited rate of approval. So around 5% is where most of them landed in improving rates of engagement in advanced care planning. There have been much more promising interventions since that systematic review was published. And one of those, if you're familiar with Rebecca Sidori's work at UCSF, she does a lot of work with older adults, so a more broader view than just oncology care. But her intervention, Prepare, is a sort of website-based intervention that walks patients through the process and has these really easy to understand low health literacy advanced directives that are amazing. I actually refer to them often in my studies. But even in that study, in the clinical trial of that study, she found a 35% increase in completion. So still much better than we were seeing prior, but there's still clearly margin for improvement there. And so part of the challenge could be that prior interventions tend to focus predominantly on just giving educational materials, but there's a robust research literature in the behavioral sciences to show that education alone does almost nothing to change people's behavior. We have to do more to help encourage them, activate them, and equip them to actually have behavior change. Some of them have focused on just discussing advanced care planning and advanced directives with patients. So this idea that a conversation is going to sort of motivate patients to engage. But once again, we sometimes see limited efficacy there. And then finally, some of these interventions have utilized end-of-life care decision aids. So walking patients through the process, thinking about the care that they would want, of course, helps and assists, but doesn't always get patients to that final point of actually having those conversations and completing their advanced directives. So questions arise, what might be missing from prior interventions? One is the role of family and cultural context is often not integrated within some of these interventions. So thinking about, what are the cultural norms around having these conversations? Who are the gatekeepers? I do a lot of work in the Latino and Hispanic community, and sometimes the patient is not always the best point of entry to having these conversations. And so thinking about what is the role of family members, loved ones, and cultural context in having these. The second is health literacy challenges. Obviously, the forms to complete for advanced directives are really, really complicated and cumbersome. So how are we helping ensure patients feel that they have the self-efficacy to do it, that they understand the forms, that they understand the decisions they're making. And that doesn't even tap into the complexity of making future care decisions when it's really uncertain, what might the many various trajectories or paths be of how a patient's health fares. We often forget to think about, how do we make the content more engaging? Something I see a lot in the work that I do is people just don't want to participate in my studies because the topic is inherently one that patients want to avoid. And so are there ways we can think about either embedding it in other aspects that really matter to patients, delivering it in a way that feels a little bit easier to access or engaging, in order to sort of enhance patients' desire or likelihood to complete the study, to complete the forms and things like that. I've touched a little bit on this, but the barrier of self-efficacy, like, do people actually know what steps to take? A lot of times, one of the biggest barriers to doing things we don't like or that are hard for us is we just need a step-by-step hand-holding instructions of like, do A, B, and C. And that is enough to give us the self-efficacy to carry out the behavior. And then finally, as I've mentioned before, we often think about the completion of advanced directives, but can we expand beyond that to really help ensure that patients are having the conversations and informing the people that if they're admitted to the hospital, are going to be the ones making the decision on their behalf. And so that kind of leads me to my program of research. So I'm really motivated to think about, how can we help make sure that patients and their family members are informed decision makers, that we're designing tools and supports that really help serve them and make this process a little bit easier to engage with and access. So as Dr. Linda mentioned in my intro, I'm a social psychologist by training, and then did my fellowship at Memorial Sloan Kettering there in the communication skills lab. So do a lot of communication-based work, and much of that lives in the palliative care and of life care space. I do note here, a lot of my work focuses on racial and ethnic health disparities, although since moving to Washington, it's been about 2.5 years now, a lot of my work is also expanding into thinking about how we can serve patients in rural settings and community-based settings where they may not have access to the traditional resources that we would see in a major cancer center like Fred Hutch. And so my program of research kind of falls into two key buckets, I would say. On the left here, you see really targeting the communication itself. So thinking about equipping and coaching and supporting patients in how to have these difficult conversations with their loved ones, with their family members, with their medical team. And then on the right side, you see decision-making and care decisions. So how can we make sure that their decisions are informed, that they truly understand their prognosis and what options are available to them and what potential outcomes might be of those options? How do we help ensure patients feel guided in documenting those decisions? And then ultimately, how can we think about improving the care that they receive at the end of life? So I want to share with you today 3 currently active study protocols here at Fred Hutch, to just give you a sense of some of the work that I'm doing and partnering with some of you on each of these projects. So the first is planning for advanced care needs. And this is a project that is specifically designed to serve patients who identify as Latino or Hispanic. And this is the conceptual model for PLAN, which is this idea that in order to encourage patients to have conversations around advanced care planning, we need to ensure that they feel competent to have those conversations. These are inherently distressing conversations, often complicated. Patients struggle to know, like, how do you casually bring this up? Is it in a clinical appointment? Is it at dinner? So thinking about how we can support them and having the competence to have those conversations. And this model and framework comes from prior work actually in pain communication within cancer care. And the idea here is that for patients to have the competence to have these conversations, they need knowledge about what it is. They need motivation to really deem it as important and be motivated to engage. And then they, of course, need the self-efficacy to know, what are the steps to take and how would I do it? And then in the study, we're also considering those sociocultural influences that do affect communication. So a patient's cultural background, their religious beliefs, if they have any, or spiritual beliefs, and any family relationships or dynamics. And the idea is that if we can improve their competence around having these conversations, we can then improve their engagement in advanced care planning. And that's being measured in this study by both the communication they're having with their family members, their loved ones, and their providers, and also completion of advanced directives. So this is just an outline of the intervention manual. So patients are given this written manual to guide them through the intervention. It's a 3-session intervention that takes place over the phone with a licensed bilingual bicultural social worker. And it uses kind of a coaching-based format. So in the first session, patients go through the first 2 modules, which is checking their awareness around advanced care planning, getting a baseline of, have they had any prior experiences? What is their understanding of it? And then moving into clarifying. So understanding any misconceptions they have, where those misconceptions came from, and then helping them sort of move into solidifying their accurate knowledge of these topics around advanced care planning, palliative care, and other related areas. Then in the second session, they move into modules 3 and 4. So module 3 is again, that's where they really solidify their learning so that we're all on the same page and having these conversations. And then module 4 is specifically focused on goal setting. So helping patients really think about what are their own values, what are their own preferences, and then how does that get mapped onto care decisions, which is where patients often struggle, is to say, okay, if what's important to me is living as long as possible, or making it to my son's graduation, or fill in the blank, like how does that actually translate to a care decision? So the coach helps walk them through some of those with some exercises throughout. And then the final session is focused on module 5, which is where they actually get some practice rehearsing, how would you have this conversation with your spouse, with your adult child, with, whomever in their life they feel that is important to, and with their medical team. In most cases, patients choose to role play thinking about what they would want to ask their oncologist, but gives them some real framework around how to begin having these conversations. And this just gives you a couple of the images included in the manual. We try
So
to.
the intern was the IT intern was like.
Oh, sorry. So we try to really focus the manual on these 2 key core concepts, which is that it's important to plan ahead. A lot of times patients sort of feel that you will just let the medical system run its way, its course, and everything will be fine. But we all know that there are varying preferences that patients have. And so reiterating that planning ahead is really important so that they can decide about that. And then on the right-hand side is this idea of collective decision-making. And all of this came from iterative feedback that we got in the early stages of this project, which I'll talk about in a moment, where we got feedback from our key informants, including the patient population we're serving. But they really like the idea of this support of loved ones, of the medical team, kind of working to help you think about the decisions that you have to make. So these are the eligibility criteria for this study. We are focusing, as I mentioned, on patients who identify ethnically as Latino or Latina or Hispanic. They do have a poor prognosis of an advanced cancer, which we define as locally advanced or metastatic. And then they did in the early phases of this research have to have also experienced a disease progression. We do have this available in English and Spanish, and so that's why you see those exclusion criteria there. Anyone who's too cognitively impaired to participate or too ill or weak to complete the interviews. And then patients who are currently receiving hospice at the time of enrollment are also not eligible. And then in the first phase, which data I'll be reviewing in a moment, we also included feedback from caregivers and providers serving this patient population. And those are the eligibility criteria for those 2 groups. So in phase 1, we got feedback on the preliminary version of this intervention. So we designed the guide, as I mentioned, based on a prior framework that had been used in pain communication and adapted it to be thinking about how it could apply to advanced care planning. And then we got feedback on that manual as well as our proposed delivery of the intervention, which is, the number of sessions we were planning to utilize, the type of interventionist and the modality. So, in-person, phone-based, or hybrid, and got feedback on the manual and those modalities from these individuals. So in the first phase, we had 11 patients, 11 caregivers, and 10 experts. Here you can see the patients were predominantly female. We did have some diversity in terms of, sorry, that should not be Pacific Islander. I apologize. That's the wrong stat there. But they were all identified as Latino. And the caregivers also had a similar breakdown, and many of them were married and partnered as well. So the results of phase 1 is that all components of the manual received high ratings. So patients and caregivers rated all components of the manual as either a 4 or 5 on a 5-point Likert scale assessing satisfaction. The highest rated module actually pertained to the communication module, module 5, which is the final session in the intervention. And interestingly, when we got feedback, module 2, which is the one where we have a checklist asking patients about their understanding and perceptions of advanced care planning, palliative care, and other aspects, was rated as the most confusing and overwhelming to patients, and the most useful and beneficial by the experts and providers. So we saw a little bit of, and then we saw the reverse for Module 5. Module 5 was rated the most highly by patients and caregivers, and they gave us a lot of feedback qualitatively about why they really liked that session, and the providers worried that it was one that wasn't as necessary. So it was really interesting to get that feedback. And what drove their preference for Module 5, interestingly, is many of them said that it gave them permission to talk to their doctor about this, that they didn't realize this was something they could ask about, and that there were specific prompts and questions included in the manual that could equip them to do that. So that was really fun finding from the preliminary feedback. All of the patients reported that they would use this manual and found it to be relevant. And some of the key feedback and themes for modifications that we got, because we did do these semi-structured interviews with patients, caregivers, and providers separately to get the feedback on how we needed to then modify the intervention. And so simplifying the materials, tailoring it more culturally to the needs of the patient population, adding a chart to have like almost a key terminology section, which we did add, and more clear guidance through the questionnaires and the exercises throughout the manual. So we made a lot of these changes and adaptations before moving into the finalized version of the intervention that we are pilot testing now. What's really interesting to me is a lot of patients reported the intervention motivated them to actually start, change, or revisit their advanced directives. And having done a lot of various intervention development studies in this domain, this was a noticeably higher rate of patients saying like, wow, once I worked through this, I realized I needed to go back and revisit my documents, or I realized I really need to prioritize and do this. Of course, this was just a feedback phase 1 study, so we did not have the data to track, did patients actually implement on that, but there was a lot of feedback in the interviews saying this really motivated them to do that. So based on that, as I mentioned, we made some adaptations to the manual and to finalizing the way the intervention will be delivered, which is, as I outlined, 3 sessions, telephone-based. Pretty unanimously, patients wanted this to be delivered over the telephone, and is being conducted with a licensed bilingual and bicultural social worker. We are currently in the sort of pilot RCT phase of this study, which is where we're randomizing 25 of patients to receive the intervention and 25 to receiving usual care, which is our control condition in this pilot. We're collecting pre and post measures at baseline and then 5 weeks post randomization. And so this is so that we can keep our study assessor blind to the delivery of the intervention, whether they got the intervention or the control condition. And then we are working across multiple sites to meet planned enrollment. So as I mentioned, this study was started when I was in New York and had a much higher access to the patient population that I'm serving. And so have spent the last couple of years as I've been moving into phase 2 of this project, into really thinking about where to the patients are that identify as Latino Hispanic, how to best serve those patients and begin recruitment in those spaces. So we are actively recruiting at the South Lake Union campus and at Harborview. I know many of you work at Harborview, and I'm happy to report we now have a really wonderful partnership there and have seen really substantial increases in our number of recruitment at that clinic. I think key to that success has been in large part just strong partnership with clinicians there who are able to sort of connect us directly to patients, in-person approaches. There's a lot of trust building, I think, that happens in that space. And patients do seem fairly interested in the study, which is great. We're also recruiting at UT Southwestern in Dallas. And then a site that we've been a lot of troubleshooting is Confluence, and this is in Eastern Washington. And have learned over the course of the study that it's just such a different population working in community-based settings, that in many ways this intervention probably needs to be further adapted and tailored to meet that patient population's needs, as well as continued coordination and collaboration with the clinical team there. So the goal here is to, of course, run the pilot RCT and make sure that this is a feasible and acceptable intervention, as well as to see if there's any indicators of potential efficacy for a larger trial where we'll hopefully be able to test this across multiple cancer centers. So transitioning, that's the first study I want to share with you today. The second one I want to share with you is called Planning Advanced Care Together, or PACT. And this is also about to go into our trial phase. We're still in the development phase, which I'll talk about in a moment. But this was designed based on an interesting framework called shared mind decision making, which is kind of being pulled from the cognitive science literature. And this is the idea that when we engage in really challenging or difficult or major life decisions, as humans, we rarely do this in strict isolation. So, you know, I always use the example of if you're to do a cross-country move, you might talk to people in your social network about that. You know, what are the motivators? What are the pros? What are the cons? What are you considering? What are you worried about? Similarly, there's been a very limited amount of research done in the context of healthcare decision making, which shows similarly patients do tend to engage with others in their social networks, as well as within medical teams, to get feedback as they're iterating and thinking about their final decision. And so this framework in this study is being mapped onto the process of advanced care planning as well. And further kind of background or foundations for this framework is that, you know, patients continuously report across a number of studies. There's been, you know, systematic reviews, including this, that they view advanced care planning as a social decision-making process. They often also report that integration of their family members or their loved ones is really important to them in having these conversations. And so there's a clear evidence that patients are already doing this or desire this. And so this intervention is designed to sort of more explicitly integrate that feedback for patients. And so part of the reason this might be really helpful is that when we fail to do it earlier on or be more intentional about including patients' social network or, you know, loved ones or family members, they may have lower rates of engaging in advanced care planning. There might be less certainty among those around them who ultimately end up making those decisions later on about what the patient wanted. And we all know that the majority of conflicts in ethical consults and critical care settings tied to this issue of disagreement among family members, among the team, patients. You know, there's a lot of conflict on how people are seeing a patient's wishes. Okay. And thank you, Dr. Lynn. I'm just now seeing your note about the Harbor View comment. So thank you so much. So these are the 4 aims of the research grant and project. And the first is to get stakeholder feedback from patients, caregivers, and providers, and to look at the acceptability and usability of the website, and to sort of iteratively develop on that. So we've just completed aim 1, which I'll share some results in a moment. And we are currently in aim 2, where we're field testing the adapted version of the website that's been optimized to meet what we would call our end user, which is the patient and their caregivers, and to do a couple of runs of iteratively developing the website further to ensure it's streamlined and ready for the randomized controlled trial in aim 3. We'll then move into this fall, aim 3, which is the RCT, and a subset of those who are in the RCT will be interviewed in aim 4 so that we can really understand the processes, how PAC operated, how they utilized it, and how we can optimize it for a larger scale dissemination and implementation. So this is a screenshot of what the preliminary version of the website looked like. So what we did is I developed this preliminary version of the website with my web developers, and had sort of these key components that were based on prior research in the literature more broadly, some pilot work I had done, and feedback from some of my key informants on the grant. We have a lot of experts across a number of fields, including oncology, palliative care, and computer science. And the central feature of PACT is that it guides patients through questions in kind of an online form base that will ultimately auto-complete their advanced directive forms, so their living will and their healthcare proxy forms, and that they can then have these PDFs mostly filled out with instructions on how to kind of finalize and complete those. In addition, there's some resources here based on prior work that I had done, which are these animated videos that describe what advanced care planning is, why it's important to think about now, which is a question and a common barrier for patients with cancer, like, why do I need to think about this now? How to communicate what they want with their loved ones and family members, and then how to communicate what they want with their doctors. So these are in the resources section. And then the people section was designed so that patients could invite people to share their, what we would call informal documentation. That's like the wishes, hopes, and worries. So if you want to share via video, text, or audio, like these are things that are really important to me. Like that would be the type of stuff that would, where a patient might say, like, I really want to make Mark's graduation next, spring. Or I want to try to reduce my time spent in the hospital, or whatever that is, where patients can't quite put it into a form, but they feel like it's important to articulate. And then formal documentation are those PDFs of the actual forms, and they can also share that with their loved ones for whom it makes sense or that they want to share. And the idea behind that is thinking that, in most cases, people have this paperwork and it's either buried in a medical record somewhere, not easily accessible at the time of needing it, or maybe they have filed paperwork, but in any case, it's not easily accessible for their surrogate to gain access to. And so that was the idea behind that. And then the document section is where those documents live. So we had patients interact with and utilize this version of the website, got their feedback, and then I'll show in a moment what we kind of iterated and developed towards that we're testing now. The patient eligibility criteria is actually very similar to the prior study. The only difference is this is open to patients who identify for any race or ethnicity. And we do currently only have it available in English right now, although would love future versions of the website to be available in Spanish as well. For just phase 1 or AIM-1, we also included feedback from caregivers and providers as well. And so again, very similar criteria here. So this is the results from phase 1 of the feedback. So this is where we got feedback from patients, caregivers, and experts on that preliminary version of the website. We have a pretty good mix of almost half female, half male for patients, which is pretty good. In most of these studies, it tends to be female leaning. The majority are married and partnered, majority white, as well as followed by patients identifying as Black. I will say the 2 sites of recruitment for this study are Fred Hutch here in Seattle and Mount Sinai in New York City. So a lot of our diversity is driven by the site in New York. These are the primary sites of cancer. So we have predominantly a lot of lung. Other is a mixture of categories, head, neck, and liver. And then these are the breakdown of the caregivers, and they are dyads. So these are caregivers that are specifically linked to those 11 patients. And then this is the breakdown of experts. So 50% oncologist, 20% social worker, 20% nurse, and 10% other, which is a combination of various APPs and others. So these are the results of the preliminary feedback on that version of the website. And these are based on cutoffs for the scores that we have for the usability. So we use the system usability scale, which is commonly used to measure usability of a website or digital intervention. And then the acceptability E-scale, which is the metric we use to measure acceptability. And so in each of these cases across patient, caregiver, and overall, we meet the benchmark. So for the acceptability E-scale, the cut point is at 68. And then for the SUS, the cut point is 68. So you see 72, 73.2, and 72.6. And for the acceptability E-scale, scores of 24 or higher are considered the cut point. So we see a good acceptability, slightly below the mark on the patients and above for the caregiver and for them combined. So based on that, we also got some qualitative feedback on the website itself. So it needed to be easier to navigate. People weren't really sure what the people section was for. The question section was a little too cumbersome. And so based on a lot of the feedback that we got in that early stage, we made some pretty substantial modifications to the website to make it a lot easier to navigate. So now when patients log in, they have a landing page that's a lot easier to navigate to the areas that they want to, and that really nudges them towards completing the document. So you see the healthcare proxy form there. We've also incorporated some of the science around what we call behavioral nudges, which is this idea that if you kind of nudge people along, they're more likely to engage in behavior change. And you see this in a lot of health apps that people commonly use, whether it's Headspace, which is a meditation app, or Noom, which is like a weight loss, healthy eating and exercise app. Kind of these nudges like, you're 72% of the way there, great progress, you only have a few more questions, that kind of a thing, to encourage them to do that. And then we changed people to allies. Participants unanimously hated the term people, which makes sense. And so we've now changed that to allies. And then those video resources, we've renamed tutorials, and we've also added a video that specifically talks about how to talk about advanced care planning in the context of having a serious illness, because many patients said they felt that it was a really different topic in that context and that they wanted to see the website be a little more sensitive to that need. So we've added that to the tutorial section. So this just gives you a flavor of some of the components of the website. So when patients, first begin, it's very explicit that the goal is to complete these forms. It lets them know exactly how far they have to go and encourages them to complete those forms. These are the ally section on the left that you see. So you can actually invite people to join PACT, and you can show them what you want to give them access to. Is it just your documents? Is it some of the wishes that you're going to share? Is it access to some of the questions you have? And you can tailor that. And this is, again, when you log in, it prompts you to complete those forms in hopes that it kind of nudges patients towards finishing that. The one on the left is an interesting one. We're in the midst of AIM 2 right now, which is getting feedback on this version of the website. And this is a section I anticipate will change drastically. The idea was to think about what are ways to help encourage patients to think about topics of discussion that might be helpful. And some of these questions were pulled from prior research and prior interventions. But we're getting a lot of feedback that some of these questions are a lot too heavy, too serious, creates a real avoidance in patients wanting to use that section. And so we'll be rethinking how to utilize that best. So as I mentioned, we're currently in AIM 2, which is where we're doing 2 rounds of kind of open trials with 10 dyads. In the first round, we sort of had them each, patients and caregivers, give us feedback on the patient version of the website. We just finished that round in our data analysis phase of that. And based on the feedback there, we'll make small iterations to the website and then begin an open trial run where we're actually going to have patients and caregivers utilize the website as a dyad. So having the patient invite the caregiver as an ally and see how the functionality works before we move into the larger trial this fall. And so we'll be testing usability, again, feasibility, acceptability, and then the user satisfaction and engagement. And so the last study I wanted to share with you today is Peacefully. This is also a website-based intervention, but is a little bit different in focus from the PACT website in that it's designed to help patients really plan for and think about their end-of-life care more comprehensively as more like end-of-life tasks. So the things that go beyond just care and what all patients have to set up if they think about potentially end-of-life. So this is grounded in goal-setting theory of motivation, which is the idea that if you set actionable goals and you give individuals adequate self-efficacy and you give them feedback on their goal progress, they are more likely to engage in the behavior change that you want to see. And so you see a lot of websites following, whether they realize it or not, they're following this kind of theory of motivation to really guide users through completing tasks that are embedded within the website. And the origin for this, this was based on feedback I was consistently getting in a lot of my interventions, which is that patients liked to focus on advanced care planning, but felt like, there's a lot of other tasks on my mind or things I have to think about as well. Wouldn't it be great if we had something that could serve that need? So the Peacefully website is through an SBIR, which means I'm doing it in partnership with the CEO of a tech company. And we are partnering to develop this tool that has two pathways. Either a patient can plan for themselves and assign a deputy so that there's really much clearer handoff of things when that person either passes away or becomes unable to engage in decision-making. Or secondarily, if someone loses somebody and now are left in the wake of all of the logistics of what you have to do when somebody passes away, they can create an account and it walks them through all the steps, everything from getting a death certificate to, how to close out accounts and how to handle things in probate. Our study is designed to test the first pathway because we're really interested in the patient perspective, but it's helpful to know that there is a secondary pathway as well. So in phase 1, we focused on, again, just refining the intervention and pilot testing it before we are going to test it in a larger pilot RCT. So we have completed AIMS 1 and 2, which is where in AIM 1, we obtained feedback from our key stakeholders, which were advanced cancer patient caregiver dyads. We assessed acceptability and usability using the same measures that we used with PACT. And then in AIM 2, we did a small open trial with 15 advanced cancer patients. Because we're targeting just the patients, the larger trial is going to be focused only on patients and not on dyads. So we are gearing up actually in May to begin AIM 3, which is the pilot RCT, where we'll randomize patients to either the intervention, where they'll get to use the Peacefully website for 4 weeks, or our control condition, which in this case is usual care. And we're looking to see its potential efficacy on improving engagement in advanced care planning and in end-of-life planning more broadly, as well as to see if secondarily it can reduce distress and improve emotional, financial, social, and spiritual well-being. So these are the patient inclusion and exclusion criteria. Again, patients with advanced or metastatic cancers, and this one is also only available in English currently. So in AIM 1, we collected data from 10 patients and 10 caregivers to get their feedback on the preliminary version of the website. So very similar structurally to the way we did PACT. And results from AIM 1 showed that we did almost meet metrics for our measures of acceptability and usability. So the dark blue, again, is the usability scores, where the cut point for success or for meeting usability criteria is 68. So across patients and caregivers, we met that metric. And then in the lighter shade blue is the acceptability scores, and a cut point there if acceptability is 24. So we did see that with patients, less so with caregivers, which was predominantly driven by the fact that caregivers were engaging with the patient version of the website. So there was a lot of feedback around wanting it to be more tailored to caregivers. In AIM 2, we collected similar measures with just patients, those 15 patients. And we, I don't have the graph here, but we did ultimately meet the benchmark for success of usability and acceptability on these scores, and got additional feedback to kind of iterate the website. So we kind of went through 2 iterations of feedback and modifications to the website to land on the revised version of it. So we are now about to kick off AIM 3 in May, and that's the RCT with 100 patients who have advanced cancer. And as I mentioned, we're going to be looking at the potential efficacy on whether it improves advanced care planning. So does it increase the rates of discussion and completion of advanced directives, the checklist itself, and that is whether they've made financial plans, dependents, healthcare, legal estate documents that map onto the website, as well as actually tracking that data within the website. And then to see if it lowers distress and improves these categories of well-being. So spiritual well-being, emotional, social, and financial well-being. A quick note to say that from phase sort of 1 to 2, where we're moving from the feedback and iterative development phase to now, some major changes were made. We reorganized how we navigate patients through the website, how we categorized each of the different features. We've integrated experts within the website, so patients now have access to, they want to be paired with a lawyer for some of the legal and estate questions. We have that feature, as well as there's also the opportunity to be integrated or matched with social workers and other mental health professionals for some of the emotional support sections of the website. So a lot of structural changes in how we guide patients through, as well as support features with the sort of matching network that's embedded within Peacefully. So I want to pause with some acknowledgements before moving on to some questions for my amazing staff and clinical research coordinators who, without whom the work would not be possible, amazing community partners and sites and the collaborators on each of these specific projects. And of course, always my clinical colleagues for whom I can honestly say what I've learned most the past couple of years here is really the key difference between being able to get patients enrolled in the study and feeling comfortable versus not. So I want to stop there, and I will pause for any questions and discussion.
Thank you so much, Dr. Shen. That was a really wonderful talk about some really important topics that come up for us a lot in the clinic. I'm happy to help sort of moderate questions that might come into the chat, or people can unmute to ask questions. While we're waiting for the first one, I'm just curious, is the Peacefully website live already, or is that something that we'll have?
Yeah, so you can actually, people can, outside of the context of the website, they can actually sign up, gain access, look at the website. Of course, within the context of the research study, patients get access to it for free. One thing that's interesting to note about that study is because it's funded through a SBIR, part of that is the NIH has you create a commercialization plan of how you ultimately roll this out. And so one of those potential pathways is like a monthly paid kind of membership. And so that's something we're also testing in the early phases, just to see how do you give access to patients? What's a sustainable model of supporting that website? But because of that, it is publicly available.
Awesome. Yeah. And do you think there'll be a model for like patients who might have trouble affording that to get assistance one day?
Yes, actually, this is a really interesting point that came up in another meeting. I'm trying to remember if it was a one-on-one or if it was a presentation, but Dr. Linden, I remember you gave us really great feedback about the Peacefully website, which was your sense was to work with certain patient populations, particularly those who might have lower health literacy or perhaps, income barriers to gaining access, and that the website itself might need to be restructured, which is also my sense. And so my collaborator, Jennifer Good, and I, what we ultimately would love to do is have a version of the website that is a little more tailored. Like we've done some feedback and gotten more direct integration from the population we're trying to serve to make a version of the website. Because right now it's very, I would say you would need to be on a certain level of health and financial and other literacy. And so we want to A, make a more tailored version, but B, absolutely what we'd like to do is integrate within our commercialization plan a way where there can be a subset of those proceeds that go towards servicing patients who do not have the means to access, but for whom this would really be a helpful tool.
Awesome. I don't see any other questions in the chat right now. Are there any other questions from the larger group for Dr. Shen?
Yeah, Megan, my question is just the health literacy thing. Like, what if they can't access the web?
Yes, absolutely. And that's why I think it's definitely not a one size fits all model. I think some of the web-based interventions are not always the best tool for all patients. So for example, with the plan intervention, that's the one that's the 3-session coaching intervention with social workers. I think the barriers to implementation there, it needs to be probably whittled down even more, although we're getting really good feedback from the way that it's designed. But I think from a healthcare systems, there's some challenges there. But that in the early phases of development and iteration, we thought about, could part of it live on a website? Does it need to be in person? Does it need to be over the phone? Could we use video conferencing? And unanimously, people didn't even want to do video conferencing just due to access issues or concerns. So I think that for some of the website-based interventions, they're just not going to always be the best mode of intervening with every population, particularly those who lack access. I could see ways where, particularly with PACT, if there were ways to have like navigators who could guide patients through the process of filling out some of those forms using the PACT website in clinic or something, or when they're in waiting areas or spaces, and then having paper versions for them. again, you have to think about though, making sure they're going home feeling informed, not just overwhelmed with forms. But I do think that, yeah, it just may not be the best fit for all populations.
Are there other questions? All right. Well, thank you so much, Dr. Shen. That was really a wonderful talk, and I think we're all excited to continue to partner on these projects, and so appreciate your time for sharing them with us today.
Yeah, thank you all for your time for attending. I really appreciate it. Have a great
Thanks.
afternoon.